Clinical examination of the alimentary system. The examiner must put the patient at ease. A sagging mattress makes examination, particularly palpation, difficult. Make sure there is good light and that the room is warm, the hands are warm. A shivering patient cannot relax and vital signs may be missed, especially on palpation. Now inspect the abdomen, noting the general contour, distension, local prominence, and abnormal masses, and also abnormal pulsation, scars, hair distribution, visible peristaltic waves, pigmentation, the umbilicus, and also engorged superficial veins. Is the abdomen of normal contour and fullness, or is it distended, or is it scaphoid that's sunken? So generalized fullness or distension may be due to fat, fluid, flatus, feces, or a fetus. So those are the 5 F's: fat, fluid, flatus, feces, or a fetus. Localized distension may be symmetrical and centered around the umbilicus, as in the case of small bowel obstruction, or asymmetrical in gross enlargement of the spleen, liver, or ovary. Note if there is any movement of the swelling, either with or independent of respiration. A scaphoid abdomen is seen in advanced stages of starvation and also malignant disease, particularly carcinoma of the esophagus and stomach. Normally, there is a gentle rise in the abdominal wall during inspiration and a fall during expiration. The movements should be free and equal on both sides. In generalized peritonitis, this movement is absent or markedly diminished as a still silent abdomen. Visible peristalsis in the upper abdomen from left to right is seen with gastric outlet obstruction, as with stenosing duodenal ulcer or pyloric carcinoma. Visible peristalsis may also be seen in obstruction of the distal small bowel, and as a normal finding in the very thin patients. The elderly patients with lax abdominal muscles or in large, wide-necked incisional hernia. So if the superficial veins are engorged, demonstrate the direction of blood flow by emptying the blood in the veins with the index fingers, and then observing which direction the veins are filled from by releasing one finger and repeating the procedure with the other finger. Prominent superficial veins may be apparent in 3 situations: thin veins over the costal margin, usually of no significance, occlusion of the inferior vena cava, and venous anastomosis in portal hypertension. In inferior vena cava obstruction, the direction of flow is upwards. Distended veins around the umbilicus as caput medusae are uncommon, but signify portal hypertension. Other signs of which may include splenomegaly and ascites could be present. Pigmentation of the abdominal wall may be seen in the midline below the umbilicus, where it forms the linea nigra, and is a sign of pregnancy. Also, note any stretch marks or striae, and this is seen in women who have born children already. It's also seen in rapid gain or loss of weight, or in patients on high dose steroids and those with Cushing's syndrome. Note any hernia or enlarged lymph nodes in each groin, and also observe the umbilicus for the site of hernia, and note if the umbilicus is inverted or flat. Normally the umbilicus is slightly retracted and inverted. A common finding in the umbilicus of the elderly obese people is a concentration of inspissated desquamated epithelium and other debris as omphalolith. So note the hair distribution. And also in liver disease, the hair distribution tends to be feminine, with the hair limited to the suprapubic line. Normally in males, the hair on the abdomen stretches to the umbilicus and other parts of the abdomen.